We have with us Professor Dr. Rauf Niazi with us. He is a chair and head of Department Internal Medicine, Endocrinology, Diabetes and Metabolism, Pakistan Institute of Medical Sciences, Islamabad. We have another renowned professor with us, Professor Dr. Yusuf Kamal. He's working as a consultant physician and consultant diabetologist at Khan University Hospital, Karachi. Uh, we have a very renowned speaker with us, Dr. Muhammad Ali Arif. He is member American Association of Clinical Endocrinology, member European Society of Endocrinology. He's working as a consultant physician and diabetologist, associate professor of medicine, Pakistan Institute of Medical Sciences, Islamabad. Without any delay, we'll hand over the session. I'm going to hand over the session to Dr. Muhammad Ali Arif to give us a brief about diabetes and Ramadan and how to modify the medicine during Ramadan and what are the precautions which should be taken. So, welcome, Dr. Muhammad Ali Arif.
Thank you, Zaim. Bismillahirrahmanirrahim. With the permission of our panelists, I'd like to begin today's session. We're going to be talking about, as the name suggests, diabetes and Ramadan, and we'll be talking about the practical guidelines that have recently been updated in 2021. So with regards to today's session, we're going to briefly touch about the epidemiology of diabetes and fasting during Ramadan. We'll talk about the physiology of fasting, the risk stratification for your patients, the management of type 2 diabetes whilst fasting, and a secondary aspect, the management of hypoglycemia and pregnancy in those ladies who wish to fast during the holy month. So very briefly touching upon the epidemiology of diabetes and fasting during Ramadan. In the year 2019, the number of people living with diabetes globally was almost 463 million, with a rise of 51% expected by 2045. A recent survey in 39 countries involving over 38,000 Muslims reported that a median of 93% fasted during Ramadan. That's a very sizable number. Therefore, we have to keep that demographic in mind and assume that a vast majority of our patients are going to wish to fast. The EPIDA study performed in 2001 found that 42.8% of people with type 1 diabetes and almost 80% of those with type 2 diabetes fasted for at least 15 days during Ramadan. Moving forward, likewise, in the 2010 CREED study, it was reported that 94.2% participants with type 2 diabetes fasted for at least 15 days, and around 2/3, that's 63.6%, fasted all days of Ramadan. And more recently, the DAR, Middle East and North Africa type 2 diabetes study revealed that 86% of participants fasted for at least 15 days. Considering that many Muslims living with diabetes are deciding to fast during Ramadan, the need for an evidence-based practical guideline is greater than ever. So before we jump into what the guidelines have to say, let's understand the physiology of fasting during the holy month. First and foremost, as we all already know, our sleep patterns tend to change, obviously, understandably so, that normally one would be sleeping in the non-Ramzan timings from usually midnight to at least 6 o'clock. However, in Ramzan, you're awake at Seher. Many of us choose to stay up from Aftar to Seher, and our sleep cycle is generally slightly disturbed. It's more fragmented and it breaks down. Likewise, because of the prolonged fasting, especially since it's still a summer fast, you can see in the screen in front of you that we do tend to develop a bit of a fluid deficit as the duration of the fast increases. Some of this is attributable to an increased urinary output, but a strong amount is also because of insensible perspiration that occurs. When the fasting hours are almost about 18 hours or so, then you can see you can almost lose up to 3% of your body weight in the course of a fast. So in non-diabetic individuals, those who are healthy, in a normal situation, we already know when there's an intake of food, it's broken down into glucose. As a result, there's insulin secretion. That inhibits gluconeogenesis via the liver and stimulates the pancreas, and we get an increased glycogen store in our muscle. Hepatic glucose output towards the muscle is also reduced. However, when you're fasting, mind you, these are for normal individuals who are fasting, the decreased food intake will lead to a decreased glucose release, resulting in decreased insulin secretion. This will stimulate and increase gluconeogenesis via the liver, however, inhibiting the pancreas and the muscle, leading to a decreased glycogen store, a depletion of glycogen stores, if you will. Therefore, it's the increased gluconeogenesis that's going to be driving the muscle intake of glucose. And a quick look at CGM profiles from healthy individuals before and after and during Ramadan, you can note the red spike that shows that there's an increase in your glucose load immediately after iftar. This in part is due to an increased carbohydrate intake, which we do tend to consume at iftar. How does this change in patients with diabetes, especially even those with type 1 diabetes? In individuals with diabetes, the underlying pathophysiology and the medications used to treat the condition will both disturb glucose homeostasis. When fasting, insulin resistance or deficiency can lead to excessive glycogen breakdown and increased gluconeogenesis, especially in people with type 1 diabetes. In addition, in type 1 diabetes, there could be an augmented ketogenesis as well. That's not to say that these individuals can't fast, but the importance as far as we're concerned, as far as clinicians are concerned, is that we need to make the correct adjustments or guide our patients to make the correct adjustments with regards to their dietary intake and their medication. Once again, CGM profiles for those who are fasting, mind you, these are diabetics. You can see that the sugars do tend to dip prior to iftar, and then there's a sudden rise. This comes down to almost a plateau and continues towards seher, and thereafter there's a continuous decline again. So a rapid increase in blood glucose is observed at iftar time. The intake of carbohydrate-rich meals at this point in time are perhaps contributory, and there's also an involvement of hormonal changes. Inappropriate timing and inadequate dosing of anti-diabetic medication can also play a contributory role. So, a burning question: how are we going to be guiding our patients? Ideally, this element should be occurring 2 weeks prior to Ramadan, where we assess an individual, stratify their risk, and start an educationally lineup. So, who should fast? We need to stratify those risks so we're well equipped to guide our patients accordingly. Now, these are a few things. I've combined the IDF-DAR guidelines and the ADA-ESD consensus statement, dividing people into very high risk, and moderate or low risk. Guidelines recommend those with a very high risk cannot fast. You should instruct them categorically that they cannot fast. It's not a matter about should. It's not a matter about desire. It's about putting their health first. These individuals will include those with severe hypoglycemia within the 3 months prior to Ramadan, severe hypoglycemia with an average fasting or pre-meal plasma glucose of more than 300 milligram per deciliter, or an HbA1c of more than 10. If they have a history of recurrent hypoglycemia or hypoglycemic unawareness, if they've developed diabetic ketoacidosis or osmolar hypoglycemic state within the last 3 months prior to Ramadan, if they've gotten acute concurrent illness, if they're performing intense physical labor, mind you, that does make a very large segment of our society, if they're pregnant, if they're on chronic dialysis, or patients with significant dementia or cognitive defects. These are those individuals that are classified under very high risk and cannot fast. Our next category is those who are high risk. They should not fast. It's advisable that they decide against fasting in the holy month. These include those with moderate hyperglycemia. That's an average blood glucose between 150 to 300 milligram per deciliter, or an HbA1c of between 8 to 10%. Type 2 diabetics with sustained poor glycemic control, or individuals well controlled on mixed insulin or multiple daily injections. Patients with well-controlled type 1 diabetes will always be considered high risk. Patients with type 2 diabetes or gestational diabetes that's being controlled only on diet or metformin, they're not on any other supplementary therapy. Patients with stage 3 chronic kidney disease. Additional risk factors, for example, the presence of comorbidities, which can be both cardiac or renal or otherwise in origin. Diabetic patients, once again, performing intense physical labor, and the use of drugs likely to affect cognitive function. The third category would be moderate to low risk. These individuals can fast if they want to. These include individuals with moderate to well-controlled type 2 diabetes with an A1C of 6.5 to 7.5, well-controlled diabetics treated with either lifestyle therapy or basal insulin, or oral agents in the form of metformin, acarbose, TZDs, SGLT2s, incretin-based therapies, or second-generation sulfonylureas. So we've stratified our individuals into our three categories. We've guided them accordingly. Now, for those who have decided to fast or wish to fast, we need to individualize the frequency of self-monitoring of blood glucose. And this will be guided by our risk stratification. We need to tell our patients that all individuals should break their fast if their glucose dips below 70. They need to recheck it within 1 hour. If it's 70 to 90, that's still an indication to break the fast. And the other extreme is if the sugars are more than 300, or if they've got symptoms of hypoglycemia or acute illness. So our education program needs to be compartmentalized. We need to quantify our risks, explain the exemptions, and remove misconceptions. What I tend to tell my patients, and I'm sure our esteemed expert panelists will agree, that it's not just us telling the patients not to fast. There are multiple religious fatwas available that have highlighted these breakdowns, supporting these guidelines. And I tell my patients that fasting isn't about causing ill health. It's about trying to improve your health. So if your fast is liable to make you feel more sick, then you are exempt from fasting. And that shouldn't be taken as an obligation to fast despite being ill. We need to increase the frequency of blood glucose monitoring, hammering home the message that that does not break the fast. We need to explain fluid and dietary advice, which I'll be touching in the next couple of slides. We need to advise them that moderate physical activity can be undertaken, provided that they shouldn't be dehydrated or exposed to extremes of temperature. We need to guide our patients with regards to medication adjustment. We need to tell them when to break the fast, as I've mentioned, with sugars less than 70 or more than 300 or any acute illness. And they need to recognize hypoglycemia and hypoglycemic symptoms. So something very interesting that I came across whilst preparing this slide deck is a Ramadan nutrition plan. We need to give them guidelines as to risk avoidance. Many diabetes-related risks can be minimized through proper nutrition. Hypoglycemia is a possibility during an extended fast, especially during the late period of fasting before iftar. Severe hyperglycemia can occur after each of the main meals. Dehydration is a possibility, especially in countries with longer fasting hours and hot climates like our own. Significant weight gain due to increased caloric intake and a reduction in physical activity is a possibility which should be avoided. There is a chance of electrolyte imbalances, and acute renal failure can occur in individuals prone to severe dehydration, particularly the elderly and those with impaired kidney function. So what we tend to guide, we should be guiding our patients, is this is an ideal nutrition plate. I do understand that this is a picture perfect aspect, and our own cultural diets may be a hurdle in this formulation, but however, I found it to be a very viable option. Advise your patients to take maybe a cup of vegetables, 3 to 4 ounces of lean proteins, 1 to 1.5 cup of whole grain rice, and 1/3 of a cup of beans, lentils, or peas. You can see that fits perfectly into 4 quarters of a nicely designed plate. For food preparation, 2 teaspoons of oil should generally be enough. We can advise 2 glasses of water. And in addition to that, 1 small slice of a fruit is a possibility. The meal that you see in front of you is providing almost 500 kilocalories per meal, with a breakdown of 45% carbohydrate, 20% protein, and 35% fat. Now, although this looks ideal, let's try to give you a few more options to consider over here. If you want at any point in time, we can ask the organizers to share this with you as well. I found it pretty reasonable. I mean, at Seher, you can advise your patients to take a 2-egg omelette, 1 wholemeal roti, which is small, a glass of milk perhaps, a little salad in the form of tomatoes or onions, a small bowl of that, and roughly 2 glasses of water. That's giving almost 450 calories. At iftar, the purpose should be not stuffing yourselves. I mean, usually the iftar meal becomes the only meal of the day. What we should be recommending is 150 to maybe a 250 calorie snack with generally a small piece of fruit, water, or an unsweetened beverage, giving you almost 150 to 240 calories. The meal, which can plausibly be taken around about 3 hours thereafter, should be giving you about 500 to maybe 750 calories. You could have, for those who can manage it, a chicken roast, palm size, lentils in the form of a curry. Vegetable curries are a possibility. You can use cooked rice. You can even use dahi bade, and a side of salad and water and unsweetened beverage. That's giving you almost 660. And a healthy snack could be taken plausibly between the iftar meal and seher, roughly 150 to 300 calories, which could be a piece of fruit, a small dessert. Well, they're recommending it. I'm still a bit hesitant there, but made with artificial sweeteners, and water and unsweetened drink. So if you were to break down your calories into 4 small meals, that could plausibly offset hyperglycemia as well and prevent bouts of hypoglycemia that are liable to occur during the day. The burning question, the management of type 2 diabetes when fasting. So let's talk first about our oral medications. Metformin is the most commonly used OAD and works by preventing the liver from producing new glucose. That is, in simple terms, it's limiting hepatic glucose output. It can come as an immediate release preparation, which can be taken thrice daily, and a prolonged release preparation, which is typically taken just once a day. Severe hypoglycemia in non-fasting individuals on metformin is rare, and although we don't have any RCT data on the use of metformin in Ramadan, it's considered safe for individuals, for those who are on metformin monotherapy, to fast comfortably. DPP-4 inhibitors effectively increase the circulating levels of GLP-1, which in turn stimulate insulin secretion in a glucose-dependent manner. Here, I'd like to also add that they're also going to act by reducing the alpha cell hyperglucogonemia. The currently available DPP-4 inhibitors, including sitagliptin, vildagliptin, saxa-alo, and linagliptin, they're usually administered either once or twice daily. They're considered one of the best tolerated anti-diabetic drugs with a low risk of hypoglycemia in non-fasting individuals. There are a few RCTs and observational studies which have examined the efficacy and safety and have found them to be absolutely safe for use during fasting. Therefore, DPP-4 inhibitors do not require treatment modification during Ramadan. A burning question would be with regards to SGLT2 inhibitors. They include dapagliflozin, canagliflozin, empagliflozin, and ertagliflozin. They've got a unique mode of action whereby they increase the excretion of glucose by the kidneys by reducing the resorption in the proximal tubule, consequently reducing blood glucose. SGLT2 inhibitors have demonstrated effectiveness in glycemic control and weight loss and are associated with a low risk of hypoglycemia. And because of this, they've been proposed that they can be a safe treatment option in type 2 diabetes in individuals who are choosing to fast. There have been some safety concerns, such as an increased risk of dehydration in patients, which may be a particularly pertinent issue during Ramadan. However, the expert panel recommendations for SGLT2 inhibitors, this is from the ADA-EASD consensus, the safety results as well as the cardiovascular and renal benefits are very reassuring. For the purpose of stabilization, these drugs should be started at least 2 weeks to 1 month prior to Ramadan. Ideally, the timing of administration should be iftar. However, if you're giving it less for glycemic control and more for cardio-renal protection, then a lower dose started in pre-Ramadan would also be acceptable. Patients are advised to increase their fluid intake during the non-fasting hours, and you don't need any dose alteration. If the patient is on a combination of medication, it's prudent to review the dosing, especially if those drugs are known to cause hypoglycemia, and we'll be talking about sulfonylureas and insulin at a later point in time. Raising awareness is very important amongst physicians about the recent guideline changes and the benefits of using these drugs. And when choosing an anti-hypoglycemic therapy, the impact on heart failure and renal function should also be considered. So the use of SGLT2s in Ramadan should be in accordance with the usual safety and prescribing measures. Generally speaking, you can avoid them in the elderly, patients who are on concomitant loop diuretics, and those with severely impaired renal function. So adjusting oral medication, let's use some practical pearls. With metformin, you don't need a dose reduction. If an individual is taking it once daily, shift that to iftar time. If it's twice daily, take it at seher and iftar. If it's thrice daily, omit the afternoon dose, which you will combine with the evening dose and take that at iftar. And if it's a sustained release preparation, please use it at iftar. With SGLT2 inhibitors, once again, you don't need dose reduction, just take it at iftar. Make sure, however, to ensure adequate hydration. With DPP4 inhibitors, once again, there's no dose reduction required. Sulfonylureas obviously will be needed to be adjusted. Generally speaking, please avoid first-generation SUs. The guidelines recommend that in an individual with relatively well-controlled sugars, reduce the dose of sulfonylureas by 50%. If it's being taken once daily, shift it to iftar. If it's taking twice daily, take the usual dose, the morning dose at iftar, and half dose at seher. Adjusting insulin. If an individual is on basal insulin, reduce the dose by around about 20%. If an individual is on twice daily pre-mixed insulin, take the morning dose at iftar and half of the evening dose at seher. If there are multiple daily injections or thrice daily insulin, omit the afternoon dose, take the usual dose, the morning dose at iftar, and half of the evening dose at seher. The considerations and the recommendations. Many individuals on multiple anti-diabetics have a long duration of diabetes, multiple comorbidities, and renal impairment. Therefore, they're at a higher risk of hypoglycemia when fasting during Ramadan. Individuals with type 2 diabetes on 3 or more anti-diabetics should receive counseling, comprehensive dietary advice, lifestyle advice, and we should be modifying their dosing prior to Ramadan. Those on 3 or more drugs, especially those on both insulin and SUs, should be considered at an increased risk of hypoglycemia. An approximate 25 to 50% reduction in the dose of insulin and a reduction in SUs around about 50% is advised. However, DPP4 inhibitors, metformin, or SGLT2 inhibitors don't require a dose reduction. Finally, we'll be touching very briefly about management of hyperglycemia in pregnancy in those individuals fasting during Ramadan. So what do the guidelines and the recommendations say? pregnant women must understand that regardless of their fasting status, they need to sustain the standard body blood glucose targets during pregnancy, fastings between 70 and 95, and postprandials less than 120. Pregnant women must also understand that during pregnancy, they should break their fasts if the sugars fall to less than 70, they feel unwell, or they feel reduced fetal movements. So regular self-monitoring of blood glucose should be ensured that the targets are achieved. At the very least, pregnant females should check before iftar, 1 to 2 hours after meals, depending upon the individual's routine, or 2 to 3 meals during Ramadan, once during the day whilst fasting, particularly in the afternoon, or any time that they feel unwell. There's also the additional risk of postprandial hyperglycemia if the meal portions are too large or too rich in carbohydrates. Therefore, a review from a dietitian would also be a very valuable tool. Exercise should be encouraged, but the schedule may need altering in its intensity and timing. So the ideal time would be 2 hours after iftar. In summary, pre-Ramzan education on adequate nutrition and meal intake and the adjustments in medication dosages and a healthy lifestyle behavior can guide individuals to fast in a safe and healthy manner. Those on multiple anti-diabetic therapies are going to be at an increased risk of hypoglycemia. They need to be counseled. All patients need to be counseled, especially those on more than 3 drugs. Those on metformin, SUs, insulin secretagogues, or insulin will need to make dose adjustments to reduce the risk of hypoglycemia. And there's no need for modification for thiazolidinediones, DPP4s, SGLT2 inhibitors, and metformin for diabetic patients during Ramadan. That brings us to a conclusion to the presentation. And I think we can move to the chat box in the meanwhile for our further Q&A session. I'd like to take things back to our host, Mr. Zaim, to guide us further as to how we're going to proceed.
Thank you very much, Dr. Ali Arif. It was indeed a very detailed and very descriptive presentation. As you are the host, kindly add Hassan Faruqi. He's Dr. Yusuf Kamal. He's attending your session.
Hold on. How would you want me to add things? Sorry, I'm still a little alien to that.
Attendees, you go to attendees and
right.
Type Hassan Faruqi. He's Dr. Yusuf Kamal, basically.
Okay. He's joining from another name. Hassan Faruqi, absolutely. And for more, we'll add as the panelist. Perfect. So I think it's pertinent here, before we formally start a Q&A, could we have the comments from Professor Rauf Niazi in the meanwhile?
Well done, Dr. Mohammad Ali Arif. As usual, it was a beautiful talk and you touched almost everything concerning Ramadan and management of, obviously, diabetic patients in Ramadan. My understanding says, Assalamu alaikum, Dr. Kamal Yusuf.
Come for you.
Jazakallah. Lovely to see you. So I was talking about my concept. From what I understand, pregnant females and breastfeeding females are already by religion exempt from fasting. So they should be told, if they're diabetic, especially, they don't need to fast at all. But rightly, if you've put it, somebody insists on fasting, then they have to be very, very careful about their tighter control. And you've touched almost everything in the subject and everything concerning the health of a diabetic patient prior to, obviously, fasting is very important. Virility, old age, comorbidities like renal failure, cardiovascular disease, ischemic heart disease, and obviously other risk factors, and the amount of work they are doing or the profession they are in, they have to be taken into account as well. And they can push a patient to severe hypoglycemia, or even can cause dehydration or lead to hyperglycemia, the other way around. So all these factors have to be taken. And unfortunately, we have to act for them not only as doctors, but have a background knowledge of Islam and guide them as muftis. Well, you cannot fast. We have to categorically tell them sometimes. You cannot fast because Islam does not allow a haram maut or dying out of hunger, because Allah looks at your hearts. And many people who would be fasting, but not for Allah subhanahu wa ta'ala, the fast would not be accepted by Allah subhanahu wa ta'ala. So one has to remember, this fasting is only for Allah subhanahu wa ta'ala. And He knows, He is alimun bi zati sadur. He knows the secrets of the heart. So one has to tell the patients very carefully and clearly that, well, the ones who cannot fast categorically have to be told, you cannot fast. And the ones who can, one has to categorize, and you rightly put it down, the high risk ones, the moderate, and the low risk ones. And we can adjust according to the medications you've rightly prescribed and told us. I think you put them very well. So if there are any questions and comments, first comments from Professor Yusuf Kamal, and then obviously questions.
Thank you, Dr. Niazi. I just specially came for you. I had a sprained a shoulder, and I just had it fixed it in the morning, but I couldn't say no to your invitation. Thank you, Dr. Arif. It was an excellent presentation. You covered everything, and the religious aspect and the other, really the aspect which Dr. Niazi covers is the essence. Are we doing it for the khushnudi of Allah, or are we doing faqa? I think that is the key element which is there. And I learned about that element when I was Saudi Arabia. You give charity. Allah doesn't want to punish His ummah. He wants them to have taqwa. And those who are in a position not to do this will give charity, and the niyat is what matters. Now, you have covered very well the fasting. I'm not going to go into that. Dr. Niazi has given the very nice view or overview. I would go back to the product which we are going to use in this for the newly discovered diabetics. After lifestyle, they are using metformin and sitagliptin. Why they are using this, and what are the advantages of this in a situation like Ramadan? First, let's bisect and dissect these two products. One is sitagliptin. What does it do? It's basically the DPP-4 inhibitor, which does not allow the breakdown of glucagon, which is GLP-1, which is produced in the intestine, and allows endogenous GLP-1 to regulate the sugar metabolism. And how beautifully it does it, that it suppresses the glucagon. It's a refresher. It suppresses the glucagon, it stimulates the alpha cells, and it inhibits neoglucogenesis also to some extent. So besides the other extra pancreatic effects, which are more in analog GLP-1s than endogenous one, these are the three main advantages. Now, if you have a low sugar level or a high sugar level, the glucagon GLP-1 molecule attaches itself and detaches itself from the cells in alpha and beta cells in pancreas according to the sugar levels in the body. So it's a beautiful regulatory mechanism of blood sugar. If the blood sugar is very high, it attaches itself to the. If the blood sugar is low, it detaches itself. So, and it also prevents gluconeogenesis. So what a beautiful model it is. Now let's come to the other drug, metformin. Metformin is an old-time drug. It took 26 years to be recognized in the United States because they were terrified of lactic acid poisoning. But then they realized that it is the cheapest and one of the best. Now, what does it do? Basically, metformin, it prevents the absorption of sugar, it inhibits gluconeogenesis, and it inhibits the glucagon release, and it also increases the sensitivity of muscles and lipid tissue. So another beautiful drug, both of them do not cause hypoglycemia. The problem with metformin is that its half-life is 8 hours, and you have to give it 3 times a day. And Pakistani patients are very sensitive to gases and gastrointestinal issues and other things like that. So if they really do not tolerate metformin very well. But the beauty of the thing is that if you combine it with sitagliptin and you give an extended release molecule, not only it reduces the amount of metformin available, but this releases over time slowly the metformin, and therefore the GI symptoms don't occur. So besides the advantages, what Dr. Arif has said, that is being neutral and all, look at the beautiful mechanism. Both of these drugs don't cause hypoglycemia, and the gastrointestinal effects of metformin are virtually neutralized by the slow release of the extended release model. Then we should not forget that after 2008, we are going to use drugs which have cardiac benefits. We are not going to use, so sulfonylureas are used in Pakistan to a large extent because people still have a glucocentric approach, although SGLT2 and DPP4 cost just as much. So it's not a cost issue. We have a very glucocentric approach that we think that once the HbA1c is 6.5, then it is fine. We add statin and antihypertensive and the patient will be fine. But look at the problems we have of the macrovascular complications with this regime. And I always say that people who just stick on to 6.5 or 7% of HbA1c and control the dyslipidemia with statins and blood pressure with blood pressure medications, they are not diabetologists. They are sugarologists. We have to move on with the time. The times are going into SGLT2 and GLP-1. Not only they have remarkable benefits ranging from 13 to 40% on cardiac failure, on renal benefits, and on benefits of 3-point MACE. So before we start those, the initial average patient who is insulin naive in Pakistan and is starting treatment of diabetes and is now going to observe fast, for him, lifestyle change and Sitaglu XR, extended release, is the best molecule we have, because not only the metformin, by the way, has a lot of cardiac benefits. It has been proven by many studies by seeing the pro-BNP, the CKMB, and also the dyslipidemia. It has remarkable effects on that. So it has cardiac benefits. And sitagliptin or DPP4s, if they may be cardiac neutral, but they definitely have benefits on hypertension and dyslipidemia in those people who have secondary cardiovascular disease. So when we are using these drugs in a combination, they have not only benefits for controlling blood sugar, maintaining it at such a level that we do not get hypoglycemia in Ramadan. And can you imagine that at iftar, if we take metformin and sitamet together in an extended release preparation, what will happen? The surge of carbohydrate is restricted by metformin and also by the release of GLP-1, but definitely by metformin. So it doesn't allow that surge to occur at that time. And when the blood sugar rises, then there's the SGLT, DPP4 coming into action, attaching itself to the alpha receptors and the beta receptors and controlling glucagon and insulin release. So we have an ideal combination. The combination is reasonably priced. It is affordable. It does not cause hypoglycemia, does not need dose titration, and has cardiac benefits. And I think for that reason, there is no better combination for those who are starting their treatment of diabetes and are taking DPP4 and metformin to take it as an extended release form. So the other things have been covered adequately by Dr. Arif, by Dr. Niazi. I just wanted to highlight the benefits of these two molecules in a combined state. Thank you.
Thank you, sir. With that
No,
note,
well, it was a poetic of narration by Yusuf Kamal Saab, and I know when he talks, it's poetry. So we always love to hear him.
Thank
And
you.
he's put it down very well. And he has a amazing sense of humor and knowledge and poetry. So one should sit with him and listen to the anecdotes and obviously poetic sense he has and beautifully put down. Lovely to hear you, sir.
It's very kind of you. I think you are biased as a friend. Thank you. And it's a mutual feeling. Thank you.
right, so without further ado, in interest of time as well, we've got quite a few questions there in the chat box and in the Q&A box. So I'm going to try to join them together. Our first question was from Dr. Waqas Ahmed. What should be the glucose monitoring frequency for non-pregnant diabetics? Now, if I may, sir, or would you like to take that question?
Please.
Right. So essentially speaking, at least 2 times is mandatory. Before iftar and at seher is a mandatory aspect there to know how things are going. Ideally, the more you monitor, the better it's going to be for you. Post iftar, 2 hours, nighttime, pre-seher, and 2 hours post-seher, and during the afternoon. So 5 pricks would be a very adequate way to go about things. That is tedious, but as far as my understanding is concerned, at least twice, ideally up to 5 times. So as if you would like to add anything there.
No, I think Dr. Muhammad Ali Arif, midday, that means around 12ish in the morning, and around 3 to 4 p.m. is also very important to check, because those are the times when the sugars are going to decline, and we need to know whether the patient is going to go into hypoglycemia or not. Especially the mid-afternoon time, that is 3 to 4 p.m. is very important. And one should be checking it, as you rightly put, pre-iftar, so that one comes to know whether if one is on insulin, for example, long-acting or pre-mixes, we can reduce the dose to adequately match the fall in glucose towards, obviously, iftar time. But I believe midday and obviously mid-afternoon checking is also very important.
We've got 2 questions from Dr. Abdul Manan with regards to the use of GLP-1 receptor agonist monotherapy during Ramzan and the use of Degludec or Glargine U300. All 3 are acceptable to be used. The important thing, in my opinion, is prior to Ramzan, gauge the patient's degree of control. That's why we've undergone risk stratification, putting patients in high, very high, or moderate or low risk. If they're moderate to low risk and they're well controlled, you don't really need to adjust therapy. GLP-1 receptor agonists can also be used without dose reduction. Degludec and Glargine U300, both being basal insulins, will generally require a 20% dose reduction. But other than that, if my esteemed seniors have anything further to add, please feel free to do so.
No, very rightly put. I think these long-acting insulins, especially the U300, that has made the risk of hypoglycemia much, much lesser than even the Glargine, which was previously available. And you can combine it with DPP4, you can combine it with metformin, or you can use the SGLT2s. And SGLT2s, as you rightly put, if they have been started at least a month or 2 weeks prior to Ramzan, they're wonderful drugs. And I believe I have experienced previously as well in previous Ramzans, my patients on SGLT2s, if they take the SGLT2 at iftar, they do not end up having dehydration or problems. But one has to be careful that one has to not mix it with diuretics. avoid the diuretics, and tell them to take adequate amount of fluids between iftar time and the seher time, not overhydrating them, but obviously adequate amount of hydration during those times. And yes, one has to reduce the dose, obviously, because it's going to be a prolonged fast. And in the month of April to May, we're going to have quite a hot weather. So one has to tell them not to overexert them with themselves and not to dehydrate themselves by going out too much into the sun, and adjust the doses accordingly. First week or so of Ramadan is very important. Checking your sugars, I tell my patients, check your sugars 2 hours after, if you're awake, 2 hours after seher, then about 12ish in the morning, and then about 3 p.m. or 4 p.m. in the afternoon, just before the iftar, and 2 hours after the iftar. That gives us a very good idea what is happening to the body, at what time the sugars are fluctuating, and how we need to intervene in between.
So we thank you, sir, for that answer.
I just have two brief comments about
Please,
the GLP-1. I think we should not start GLP-1 in Ramadan because, in the first 2 weeks, there is always a lot of nausea, and I think it's not fair to start people on GLP-1. So those who are already on GLP-1, it is all right. Then I was asked two questions that now we are getting newer preparations like Zultrophy, which is a combination of GLP-1 and long-acting degludec. And soon we'll be getting Siliqua, which is a combination of U300 and short-acting lixanatide. Now, how will we adjust that? Now, basically treated as basal insulin. In terms of component, the GLP-1s will not cause the hypoglycemia. It is the basal component which is important, and they should be treated like basal insulin. So the same way as Dr. Arif said, most of the basal insulins do not need change. These basal insulins will, the combination Zultrophy and Siliqua will also need not much change, except that if you want to and check the blood sugar levels 2 hours before, 2 hours after iftari, and then you have a mechanism that you can reduce the dose by 15% of the basal component of these products.
So thank you so much for that add-on, sir. Our next question is, what dose adjustment should be made for sulfonylureas in Ramzan? I believe I touched upon this during the session itself. I'll just repeat that again. First and foremost, try to avoid the first generation sulfonylureas. That's the first message.
I'm sorry, Dr. Ali, I'm sorry. Just say avoid glibenclamide.
Oh, okay, I'll be more blunt, sir.
Boldly say that.
Please avoid glibenclamide, especially in Ramzan. Thereafter, if you're using a sulfonylurea once daily, the overall dose reduction that's recommended in the guidelines is 50%. Therefore, you will be halving the dose of the sulfonylurea, and it will be shifted to iftar if it's taken once daily. If you're taking it twice daily, for example, just for the purpose of discussion, an individual is on either gliclazide or glimepiride twice daily, then after that 50% dose reduction, take the morning dose at iftar and half of the evening dose at seher. That would be a very wise way to use it.
For the sake of discussion, again, I'll come to that point. Yeah, I will come to the discussion of the point that why use sulfonylureas? I mean, look, if it's a question of affordability, then it's a different thing. But then the price of sitaglumate and XR and SGLT2 is the same as Emeril and dimicron. So, I mean, I still really do not understand that why we must pursue the sugar-centric approach when we know that sulfonylureas have no cardiac benefits and may even do harm. So we must make a mindset change.
I would agree and echo Professor Yusuf Kamal's point of view. I think the question that's being asked, sir, just for a bit of understanding is we will have lots of patients who may come to us after seeing various other practitioners and may already be on an existing SU formulation, maybe in addition to taking an SGLT2 and sitaglutide XR, for example. Therefore, those individuals who are well controlled, let's say they've got an A1C of 6.8, now, just discontinuing their SU prior to Ramzan might not be the best strategy for us to employ. So if those individuals do wish to fast, we could make a dose adjustment, and after the holy month is over, we could perhaps decide on further treatment options for them as well. But quite frankly, in my limited understanding, I wouldn't want to rock the boat to that degree. If I've got relatively good glycemic control prior to Ramzan, I wouldn't want to discontinue a medication in its entirety. I might want to step it down. But your point, sir, is absolutely valid. With the armamentarium of drugs available that are providing benefits, we shouldn't be purely and wholly sugarologists. We've got lots of other things to take into account as well. And I think you've made a very, very valid point over there as well.
Vinay, very well answered, Dr. Muhammad Ali Arif. But Dr. Yusuf Kamal's message has to be spread.
Agreed.
And he's made a point. And I totally
very valid
agree with
point.
him. He's made a very valid point. What I tend to do is that my diabetics, if they want to fast a month prior to, before they visit me, before Ramzan, I'll tell them, are you going to fast? The Ramzan is approaching. And I tell them to shift on to, if they are on sulfonylureas and they're not well controlled on, my first choice is a combo of metformin. Start with metformin. I start with metformin or SGLT2. Add on DPP4. If the 3-drug combination is not controlling their diabetes well, and they need a 4th drug, for example, I would opt for a long-acting, maybe 30 glargine 300, or maybe another long-acting insulin. Or maybe I'll try to shift them over to Zultofy, if need be, which is a GLP-1 analog with insulin. Or I tell them, I'm going to shift you on to long-acting insulin before Ramzan. And I adjust the dose accordingly so that I don't need to give them sulfonylureas during Ramzan. And once they find the ease of getting the insulin and getting their sugar controlled very well with 1 shot of insulin, and along with maybe combination of metformin with DPP4 inhibitor, and obviously SGLT2s, they come to understand it's very good, easy, not very expensive. And I agree with Dr. Yusuf Kamal that obviously sulfonylureas, maybe in future, we won't even see them around.
Until that point in time, sir, and since there are burning questions from participants all through the country, so SUs, obviously there will come a time, but I agree with you, they will be phased out. But until they are being used in clinical practice, I feel it's our duty to inform our colleagues as to what the guidelines have to say and how we should be using them. So we have a few more questions. There's a question from Dr. Gohar Ali. What about fasting in type 1 diabetes? At the outset, during the initial segment of the presentation, for type 1 diabetes, fasting will always be considered very high risk. So the IDF-DAR guidelines recommend that type 1 diabetics should not be fasting. Obviously, in a type 1 diabetic, the usual regimen will be multiple daily injections of insulin. In the vast majority of patients, they might be on thrice daily pre-mixed analogs as well. There are multiple regimens that they might be following. For them, the same thing will apply, that you will be omitting the afternoon dose, but you won't be changing the seher and iftar dosages. You won't be making a reduction in their insulin because technically these people don't have a functioning pancreas. So you cannot count on any pancreatic reserve. You can't cover with any oral agents with them in the first place. So keeping that in mind, I would still suggest that urge your type 1 diabetics to take advantage of the religious leverage that they've been given, that they are free not to fast. They're not they don't have any compulsion to fast because their health doesn't allow them to do so. To my esteemed panelists, would you like to add on?
No, very rightly, I tell my patients, look, Allah subhanahu wa ta'ala clearly says that till Allah does not lift Quran from this earth, the message is going to be there that a traveler and a sick person, and type 1 diabetes is a very, very sick person, they're exempt from fasting. And you have to tell them you're exempt from fasting for God's sake. Don't be a nashukra. That's nashukri. When Allah has allowed you not to fast, why go for it? One has to understand, magar ye jo hota hai na, nahi ji, humne karna hai. This is a trend which you cannot undo. So you very rightly put some of them, but please tell them. You rightly put, give them 2 times. You don't you reduce the dose. Take it twice daily. Have adequate hydration before you fast. But important thing is they need to check their sugars frequently, more frequently than the type 2 diabetics. And if any time the sugars go below 70, they have to break their fast. And in doing so, I'm not a mufti, but I was told by a religious scholar, they're not punishable by that thing that in Sharia that they have to feed 60 people. It's just like they have to break their fast and they have to give alms for a person to have iftar and seher. That's the fidya for that. That's the fidya for that. But one has to categorically sometimes tell them, no, you cannot fast. So for type 1 diabetics...
It's not a question of Dr. Niazi saying it or me saying it or Arif, you saying it. There are fatwas from Al-Azhar, from our religious leaders in Makkah. I mean, known fatwas for this. So we are not inventing the wheel. I mean, why would they say that? I mean, they are renowned scholars, much more knowledgeable than us, and which gave us the real meaning of Islam as to why we are fasting.
Yes, agreed.
Thank you, Saz, for a very solid answer. I hope that would clear up all misconceptions, if any exist. The next question is, can sitagliptin be started in Ramzan while stopping a sulfonylurea? If I were to give my 2 cents on this, stopping or making major adjustments just prior to Ramzan wouldn't be the best way to manage diabetes, because that's why all guidelines recommend that 2 weeks to 1 month, a patient should be on stable medication so that dosages can be adjusted accordingly. I frankly wouldn't be inclined to make a quick switch, throw out the sulfonylurea and add sitagliptin at that point in time. Before jumping onto the Ramzan bandwagon, I'm sure most of our patients are with regular follow-up. And quite frankly, I start prodding my patients a month prior to Ramzan. कि जी खैर वाफियत से रमजान आ रहे हैं, आपका इरादा है रोजा रखने का? For those who say yes, then I'm like, okay, we're going to make adjustments. Please check your sugars regularly so that we can prime you well in advance for the holy month to start. Sirs, would you have anything else to add on?
I'm putting my dollar in your cup. That's the answer I would give, honestly.
Thank you, sir. Professor Yusuf, would you have anything to add on?
No, that's perfect. Fully agree. Only thing is that whenever we have these meetings, I think we have a very rare opportunity to address so many people. And I think we always have to throw in what is the correct thing to do, like changing from human insulin to analogs, like getting rid of sulfonyl. We always must make this point. It's not a question of answering their question, but with conviction that now it is we have to be cardiocentric and not sugar-centric. I mean, I think it's a mindset change. And if our practitioners are trying their best to control the sugar with without caring for what happens to 3-point MACE and cardiac failure and renal failure, then we are not really treating diabetes. I mean, that's the mindset change. In each one of our meetings, we should make this point. But for those who are following it already, this is not the month to change, but they have to keep this in mind.
Very true.
Well
sir.
said.
Very solid point.
Very well said, that we have to spread this message that it's not sugar lowering, it's addressing basically the cardiac and the renal complications. But as you rightly put it down, well, Ramadan is not the time to change, but Dr. Yusuf Kamal is spreading the message. Well, hey, this is not the right way to treat. The right way to treat is what Dr. Yusuf Kamal is trying to convey. And that should have been done 6 months or maybe from the very beginning. But now, when the month of Ramadan has approached, that's not the time to change things. So I'll let you carry on with the further questions.
Thank you, Saz. Okay, this is from Dr. Abdullah Khan. He's got a question. Can we recommend using Sitaglutide XR 100 by 1000 once daily instead of twice daily in Ramzan for better glycemic control? If I were to understand the question, Dr. Abdullah is asking about using an extended release preparation of metformin in addition to a DPP-4 versus regular release metformin with a DPP-4 twice daily. If you were to ask me for my personal take, I'm a fan of extended release preparations. I find that using Sitaglutide XR once daily is a wonderful way to control the sugars. Convenience and patient compliance gets much better if they have to take a pill once a day. Multiple pills throughout the day, polypharmacy, tends to decrease compliance as well. And there's always a chance that the patient might miss taking his or her medication. So yes, if the situation allows you to do so, using an OD preparation of an extended release salt would be a very wise option to use. And as Professor Yusuf Kamal rightly pointed out, you'll be limiting the GI adverse effects of metformin when you're using it in an extended release preparation. So I think it's a win-win situation over there. And I'd like the take of my expert panelists as well.
Changing twice daily SGLT2 DPP4 to an extended release one, once daily, I don't see any harm in doing that. And I totally agree with your take that and what you put up. There's no harm. But generally, again, Ramzan is not the month for changes, making changes or jumps. So if my patient is generally controlled on twice daily and came to me for the first time and is well controlled, I would not jump to an extended release. I let them do that, continue during Ramzan, watch their sugars, tell them to watch their sugars. And if they're doing well, maybe after Ramzan, I can switch them over to an extended release combo later on. One thing which I think you've been trying to convey and what we've been trying to convey is Ramzan is not the time to make sudden changes in treatments. If the patient's been on a drug for a while and is well controlled and you've allowed them and you found they have a low risk of getting hypoglycemia or hyperglycemia, or they fall into the low risk category with no comorbidities, then what I would tend to do is to continue with the regimen and make changes later on, not during the month of Ramadan.
And we have our last question for today in the interest of time. The question deals with using a once weekly GLP like Trulicity and what can they fast or not. I'd invite our participants to revisit the slide deck that we've shared. The first aspect is, have we, in our capacity as pseudo-muftis, allowed our patients to fast or not? Or what guidelines have we recommended for our patients, should they be fasting or not? The second aspect is, how well controlled are they? If an individual is well controlled using dulaglutide, yes, it does have its GI side effects, but mind you, just echoing what Professor Rauf Niazi just said a few moments ago, Ramzan isn't the month for experimentation. I'm not going to be starting a once weekly GLP-1 on the 1st of Ramzan because I have no idea how my patient's gut is going to respond to it. However, if a patient has been using dulaglutide or, for example, daily liraglutide in the months preceding Ramzan, and they're doing relatively well, and their gut is tolerating things comfortably, I see no reason to discontinue or limit their choice of fasting as a result of being on this medication. But I'm not going to start it with Ramzan happening in 2 days' time.
Very rightly put. Very rightly
Very
put.
right. Very right.
And that, I believe, brings us to the conclusion of this Q&A session as well. Zaim, I'll hand the microphone back to you for the Hilton platform. Let me take this opportunity to thank both Professor Rauf Niazi and Professor Yusuf Kamal for taking the time out for joining us here today. It's been a thoroughly interactive session. I frankly enjoyed myself extensively. I hope our participants did so as well. And I would like to extend my thanks to our colleagues at Hilton for making this possible. And Zaim, over to you.